welcome to the deep dive. If you are preparing for clinical rotations, facing professional benchmark exams, or, just need to master the highest stakes concepts in patient care, you are in exactly the right place.
We're moving past those exhaustive textbook chapters and really just distilling the knowledge you need. The goal is to help you be a safe, effective, and prepared healthcare provider.
Today, we are undertaking a deep dive into one of the most consistently challenging and, I think, critical areas of nursing practice, cognitive disorders.
That's right. Specifically, we are going to dissect the differences between delirium and dementia. And recognizing these distinctions, it isn't just academic.
No, not at all.
It's the difference between a patient getting life-saving, acute medical intervention versus, long-term support. They are two completely different paths of care.
Absolutely. And our source material today is focused entirely on professional preparation. We're talking nursing module excerpts, established clinical guidelines, and a lot of high-priority practice questions.
So our mission is to give you a structured, high-yield review framed exactly how you'd see it in a major exam setting.
Right.
To set the foundation, the crucial distinction you have to internalize is all about time and trajectory.
Okay.
Delirium is the acute, sudden, and often reversible cognitive emergency. It's a sign of an underlying physical illness or maybe a chemical imbalance that demands immediate attention.
And dementia.
Dementia, on the other hand, is the chronic, insidious, and progressive decline of cognitive function. It's a long, slow process.
That distinction, acute versus chronic, reversible versus progressive, that is the whole ball game. But I think it's important to say that regardless of whether the confusion is sudden or gradual, the nursing priority remains constant.
Precisely. The overriding nursing priority in the care of any patient experiencing cognitive impairment, acute or chronic, it centers overwhelmingly on patient safety.
Always.
A confused patient, just by definition, is a high risk for injury, and we're going to use that safety focus to frame every single intervention we talk about today.
That really clarifies the foundational distinction. Okay, let's unpack this. We'll start with the acute condition, delirium, which acts as this rapid clinical flag demanding immediate action.
Right. Delirium, which you'll sometimes hear called an acute confusional state, is defined by an abrupt disturbance in attention, consciousness, and cognition.
And when you say abrupt,
If you're assessing a patient and their family reports a major shift in mental status that occurred over hours to days, that is your definitive clinical indicator for delirium. It's a sudden, sharp break from their baseline.
that suddenness is absolutely paramount.
Mm.
If you see a practice question where a patient who was totally lucid yesterday is now pulling at their lines and talking to people who aren't there, that speed just completely rules out the insidious onset of a stable dementia.
Exactly.
So what are the core features we see in these acute disturbances?
Well, the clinical features are highly dynamic, and they're often pretty alarming for everyone involved. First and foremost is the impaired level of consciousness and attention.
And how is that different from what we see in dementia?
Unlike stable dementia, where the patient is generally awake and alert but forgetful, the patient with delirium can fluctuate wildly.
What does that look like on the floor?
One moment they might be lethargic, barely responsive to commands, and then the next they could be highly agitated, trying to climb out of bed. That fluctuating and altered level of consciousness is a classic sign of delirium.
That fluctuation is what makes nursing this condition so challenging and, frankly, exhausting for caregivers. Let's talk about the specific disturbances in perception, because those are often the scariest part for the patient.
Definitely. We see two main types. The first is hallucinations. These are sensory experiences, visual, auditory, or tactile, that are not based on any external reality.
And the sources say visual are the most common here.
Yes, our source material confirms that visual hallucinations are the most common type seen in delirium, and that's a key NCLEX distinction compared to something like schizophrenia, where auditory hallucinations are usually the ones that predominate.
Okay, and the second type of perceptual disturbance?
The second type is illusions. This is a misinterpretation of a real external object.
Right, the classic example you always hear about.
It's the classic for a reason. You'll see it in clinical scenarios all the time. A patient mistaking their IV tubing or a telephone cord for a snake, or misinterpreting a spot on the wall as a giant bug.
So the object is real, the tube is there, but their brain is just misfiring.
The brain's disturbed filtering mechanism interprets it incorrectly. And this is exactly why our subsequent interventions focus so heavily on modifying that sensory environment.
We also see a major disruption in the body's internal clock, right? The sleep-wake cycle.
Yes, a dramatically disturbed sleep-wake cycle.
Yeah.
They might sleep all day and then become severely agitated and confused at night.
Sundowning.
Exactly. That nocturnal worsening is what we clinically term as sundowning. It's important to note, though, that sundowning can happen in both conditions, but it's often much more severe and rapid in delirium because of that acute state of metabolic disruption.
And their speech.
Speech is typically rambling, often incoherent. The patient may have a lot of trouble initiating or just completing a thought.
Before we move to care, we have to talk about the different types of delirium. The presentation really affects the risk assessment.
Right. Clinically, we identify 3 types. There's hyperactive delirium. This is the one everyone thinks of.
The stereotypical presentation.
It is. The patient is agitated, restless, hyperalert, maybe paranoid, yelling, and very prone to pulling out tubes. This is the type that is most visible and causes those immediate glaring safety concerns.
And then there's the counterpoint.
Which is hypoactive delirium. And this is actually the most common type, especially in the elderly, and it's often the most missed.
Why is it missed so often?
Because these patients are quiet, they're lethargic, slow to respond, withdrawn, and they appear sedated. They aren't causing a disturbance, so they often don't get the immediate investigation they need.
But that can lead to worse outcomes.
Much worse outcomes. It's often associated with things like poor nutrition and a high risk for aspiration.
And then there's a mixed type, where they just shift between hyperactive and hypoactive states. So how does the nurse, acting as a clinical detective, figure out the root cause? Because that's the only way to really treat delirium.
You have to look for the triggers. The causes are almost always medical or chemical, and you have to know the common culprits. We usually categorize them into the big 3. First, infections.
And specifically, in the frail and elderly population, we are talking about pneumonia and urinary tract infections, UTIs.
Exactly. A UTI can trigger a systemic inflammatory response, leading to what we call cerebral encephalopathy. You might have an 85-year-old with a sudden change in behavior, but no fever, no localizing symptoms.
And the confusion is the first sign.
It's the change in mental status that flags the severe infection, often days before other signs appear.
Okay, so infections are number 1. What's number 2?
Second, we look at metabolic imbalances.
This is a huge category.
It's a huge category that includes dehydration, which is rampant in older or sick patients, severe electrolyte issues, especially low sodium or high calcium, and blood sugar derangements.
Like hypoglycemia.
Hypoglycemia or severe hyperglycemia. If a patient's glucose is running at 400, the kidneys are struggling, the brain is struggling, and confusion is highly, highly predictable. We also look at low oxygen levels and acute organ failure, like kidney or liver failure.
And the third major category, which demands incredible nursing vigilance, is drug effects. The source material is very, very clear here.
We need extreme vigilance regarding medication side effects, especially anticholinergic medications.
Why those specifically?
They are notorious triggers because they cross the blood-brain barrier and they block acetylcholine activity, which is crucial for cognition. Think diphenhydramine or Benadryl, certain tricyclic antidepressants, and some medications used for bladder control.
And we also look for things like opioids, corticosteroids, and just polypharmacy in general, right?
Oh, absolutely. Anytime a new drug is added or the dosage of an existing drug is increased and the patient suddenly becomes confused, the nurse has to suspect iatrogenic delirium. That's treatment-caused delirium.
So the takeaway is, if you assess a patient and find a rapid change in consciousness linked to a new medical issue or a new drug, you've pretty much clinched the diagnosis of delirium.
You have. And now the clock is ticking to fix that underlying cause.
Let's pivot to the care priorities, because identifying delirium is only step 1. This is where the clinical action begins. And the first, highest yield principle repeated across every module is that the priority outcome in delirium is client will remain safe and free from injury.
That is non-negotiable. And this guides the critical choice between intervention and restraint. We know the delirious patient might fall, pull out of central lines, or strike out due to paranoid fear. Our first line of defense is always non-pharmacological safety measures.
And this brings us to that critical point on restraints. The sources are definitive. Physical restraints are almost always avoided, if at all possible.
Restraints are a measure of desperation, not prevention. They tend to increase the patient's fear, their agitation, and their struggle against the restraints, which often results in, friction burns, circulatory compromise, or even falls when they try to escape.
So what's the alternative?
Our preference is always close, consistent, high-level supervision. a bedside sitter, a family member, or just ensuring the nurse or aide is consistently present in the room.
So we establish constant supervision, but we also have to manage the environment itself, right?
Right.
Particularly to minimize those terrifying perceptual distortions we just talked about.
Right. The environmental management has to be nuanced. We want the room to be quiet, predictable, and hazard-free. Crucially, the lighting should be soft, diffuse, and consistent.
You have to eliminate harsh shadows.
You have to eliminate harsh shadows. Remember, those shadows can be misinterpreted as threatening figures or objects, which triggers fear and agitation.
At the same time, we have to maximize sensory input to anchor the patient in reality.
That means ensuring their hearing aids are clean, functioning, and in place, and their eyeglasses are worn and clean. Sensory deprivation can make confusion so much worse.
But then you have to balance that with minimizing overstimulation.
Exactly. We advise family to visit one at a time, keeping the room calm. Excessive noise or multiple unfamiliar faces can trigger a heightened sense of threat. Consistency is key, so we keep familiar objects in sight.
Communication is the nurse's primary tool in this acute state. How do we communicate effectively when the patient's internal world is just breaking down?
The foundational technique is extreme simplicity. Use simple, short sentences. Give one instruction at a time. And speak slowly with a gentle, non-confrontational tone.
And then you have to wait.
You have to allow an extended pause. Silently count to 5 or 10. Give that impaired brain adequate processing time before you expect a response.
And frequent reassurance is essential, establishing safety and orientation. I am Sarah, your nurse. You're safe in this hospital room. But how do we handle the hallucinations or illusions without lying or confronting them?
This is such a critical skill for therapeutic communication. You have to acknowledge the feeling while gently redirecting the reality.
So if a patient is pointing at the wall, terrified, saying there is a snake,
the worst thing to say is, "There is no snake." That just invalidates their terrifying experience. It tells them you don't believe them.
so what's the preferred response, the one drawn directly from clinical guidelines?
It balances validation and reality. You would respond, "I understand that you are scared right now. I don't see a snake. I see the air vent, but I will stay right here with you to make sure you are safe."
So you validated their terror, I understand you're scared, offered the factual reality neutrally, and then provided the reassurance of protection.
Exactly. The focus is on security, not on being right.
Now, on to treatment. We established that delirium is reversible. So what is the core medical intervention?
The primary treatment is always to identify and aggressively treat the underlying cause. Delirium is a symptom of physical distress. If it's dehydration, we correct the fluids and electrolytes. If it's a drug, we hold the drug and consult the pharmacy or provider. If it's sepsis, we start the antibiotics and supportive care immediately.
And that supportive care, hydration, nutrition, environmental safety, that continues while the cause is being fixed?
It does.
But what if we're treating the cause, but the patient's agitation is so severe that they pose an immediate risk of harm to themselves or staff? When do we turn to pharmacology?
Medications are reserved as a temporary chemical restraint for severe, dangerous agitation or psychosis. The first-line agent is often a low dose of the typical antipsychotic haloperidol.
And what are the nursing considerations for using haloperidol, especially in the elderly?
We monitor for 2 main things. First is efficacy. Is the patient calmer, less agitated, and better able to follow simple directions without being overly sedated? We want calm, not coma.
And second?
Second is safety. Haloperidol can prolong the QT interval on an ECG, which increases the risk of serious arrhythmias. So we often monitor vital signs and perhaps the ECG, especially in patients with a cardiac history.
Okay, and let's reiterate the major cautions surrounding the use of benzodiazepines like lorazepam or Ativan.
Benzodiazepines are generally contraindicated for delirium. They frequently cause a paradoxical effect, so they actually worsen confusion and disinhibition, especially in the elderly.
But there's one crucial exception.
There is, and this is a high-yield test point. The exception is if the delirium is specifically caused by alcohol or sedative withdrawal. In that very specific scenario, benzodiazepines are necessary to prevent dangerous seizures and cardiac instability. Otherwise, you avoid them.
The ultimate outcome here is positive, but it sounds like patience is required.
A lot of patience. While delirium is usually reversible, the process is not instantaneous. Full cognitive clarity might take days or even weeks, particularly in patients who are frail to begin with. The nurse has to continue with orientation and safety measures until the client returns to their established cognitive baseline.
So if delirium is the acute, treatable medical flag that demands immediate detective work, how does that priority evolve when we look at the long-term reality of chronic dementia? Now we transition to that insidious chronic journey.
Right. Dementia is the umbrella term for a large group of neurocognitive disorders. They're characterized by multiple cognitive deficits that are severe enough to significantly impair social and occupational functioning.
And this isn't just normal aging.
No, this is a catastrophic break in the ability to function independently.
And the distinction in onset is absolute. If delirium is hours to days, dementia has an insidious onset, developing gradually over months or, more often, years, showing a steady, predictable decline over time.
And that stability in the decline is really important. Unlike delirium, the person with stable dementia usually maintains a clear level of consciousness until the very late stages.
So they're alert and awake.
They're alert and awake, but their ability to access information, use language, or process complex commands is compromised. And if a change in cognition occurs suddenly, over 24 hours, that signals an acute medical problem. That's delirium on top of their chronic dementia baseline.
And the prognosis is vastly different.
Most dementias are currently irreversible and progressive. We might be able to slow the progression, but we do not restore lost function, with very, very few rare exceptions, like dementias caused by a severe B12 deficiency or normal Crusher hydrocephalus.
Okay, let's dive into the hallmarks of dementia, specifically Alzheimer's disease, which is the most common form. We need to master the 4 clinical deficits, often referred to as the 4 A's, plus the executive function impairment.
The defining feature is memory impairment, or amnesia. This nearly always presents first as difficulty recalling recent information, what they ate for breakfast, a conversation they had 5 minutes ago.
But they can remember things from long ago.
Early on, remote memories from 50 years ago may be surprisingly intact. This is why when a nurse talks to family members, their ability to recognize those significant short-term memory deficits is often the earliest sign they notice.
Okay, that's amnesia. Next, let's move to aphasia, the language disturbance, which can dramatically impair communication.
Aphasia starts subtly. Maybe just difficulty finding specific words, which we call anomia. The patient knows what they mean, but they can't retrieve the word. So they might use vague phrases like, that cooking thing for a stove?
And it gets worse over time.
As the disease advances, expressive aphasia, the inability to produce language, worsens. This can lead to fragmented sentences or the use of repetitive words or phrases, something called perseveration, like, I want to go home, I want to go home.
And they also struggle to understand.
Right. Receptive aphasia, where they struggle to understand spoken language, also develops later, making communication almost impossible.
Then we have agnosia. So if aphasia is losing the word, agnosia is losing the recognition.
That's a great way to put it. Agnosia is the inability to recognize familiar objects, sounds, or even people, despite having intact sensory organs. Their eyes are working perfectly, they can see the pencil, but the brain cannot connect that visual input to the knowledge that the object is called a pencil and is used for writing.
And how would a nurse test for that?
If a nurse shows a client a common object, like a fork or a key, and asks them to name it or describe its use, and the client fails, that's a clinical test for agnosia.
This means they often struggle to recognize their own family members in later stages, which is just heartbreaking for the family.
It is.
Now, the 4th A, which has huge implications for basic patient care, apraxia.
Apraxia is the inability to perform purposeful motor activities or to sequence routine tasks despite having the physical ability to do so. They have intact motor function.
So they know they want to get dressed.
They know they want to dress themselves, but they cannot sequence the step socks before shoes, pants before the shirt. They've lost that procedural memory.
This is why the clinical testing of apraxia is so important for the nurse. So how do you test for it?
To test for apraxia, you ask the patient to perform a learned sequence of movements, like pretending to brush their teeth or comb their hair. If they try to sequence the action incorrectly or they just can't initiate the action at all, that confirms apraxia. And this directly impacts how we assist with activities of daily living or ADLs.
And finally, we have to include impaired executive function. This is that highest level of cognitive decline.
Right. Executive function includes planning, organizing, judgment, and abstract thinking. This is why a patient can't manage their finances, or follow a complex medication schedule, or adapt when a routine is unexpectedly changed.
And this includes a lack of insight into their own problems.
Yes. This loss of insight into their own deficits, the inability to recognize that they are having memory problems, is a key concept called anosognosia.
Anosognosia explains why confronting them is so damaging. I mean, if the patient genuinely doesn't realize they're forgetful or impaired, accusing them of forgetting something is just extremely distressing for them.
It leads to what we call catastrophic reactions. The patient experiences overwhelming anxiety, anger, and agitation when they're forced to confront their disability, and this is often triggered by being quizzed, hurried, or overstimulated.
Speaking of pathology, let's briefly touch on the underlying cause of Alzheimer's disease, the primary dementia.
The pathological hallmarks of Alzheimer's are the accumulation of beta amyloid plaques outside the neurons and tau neurofibrillary tangles inside the neurons.
And these just gum up the works, basically.
Essentially, yes. These abnormal protein deposits disrupt neuronal communication and transport systems, and that ultimately leads to widespread cell death, especially in areas that are crucial for memory, like the hippocampus.
And that cell death is what results in the observed brain changes, that extreme shrinkage of the cerebral cortex and hippocampus, and the resulting severe enlargement of the ventricles.
And this leads directly to the core pharmacological principle we need to understand, the neurotransmitter connection. The neurons responsible for producing acetylcholine, or HE, a neurotransmitter critical for memory and learning, are heavily destroyed by the disease process. This cholinergic deficiency is the target of our primary drug interventions.
We should also briefly differentiate the most common forms of dementia, as the presentation can really guide a clinician's suspicion.
Absolutely. Vascular dementia is distinct. It results from multiple small thromboembolic or ischemic events, mini strokes, that block blood flow to brain tissue.
So the decline looks different.
Right. The clinical course is characterized by a stepwise or stuttering decline. You see these sudden, abrupt drops in function that correspond to new vascular events, and then they're followed by periods of stabilization.
And the risk factors are what you'd expect.
Exactly. High-risk factors are hypertension, diabetes, and cardiovascular disease. A nurse seeing sudden focal neurological changes or temporary slurring of speech would highly suspect a vascular component.
Then there's dementia with Lewy bodies, or DLB, which is often mistaken for Alzheimer's or Parkinson's.
DLB features cognitive decline, but it also includes prominent, vivid, recurrent visual hallucinations very early in the course. And it includes Parkinsonian movement symptoms like rigidity and tremors. These patients are also often extremely sensitive to antipsychotics.
And finally, frontotemporal dementia.
This form primarily affects the frontal and temporal lobes, so it often presents with marked changes in personality, judgment, and social behavior rather than memory loss, at least initially. They might become disinhibited, impulsive, or apathetic.
And understanding these progression stages is vital because the nursing care shifts so radically based on their level of function.
It does. In the mild or early stage, the client is forgetful, but often aware of their deficits, which frequently causes anxiety, fear, and depression. Nursing care is largely supportive. It involves gentle reminders and emotional validation.
And the moderate stage.
In the moderate or middle stage, pronounced memory loss sets in. They need extensive help with ADLs, and behavioral changes like agitation, suspiciousness, and wandering become the primary concerns.
And by the severe or late stage?
They are completely dependent on others for all care. Communication is often lost, they lose the ability to ambulate safely, and the risk shifts to physiological complications like aspiration pneumonia, malnutrition, and pressure ulcers.
So if the long-term reality is this chronic decline, how does that initial priority of safety translate into chronic management?
Well, the top priority in advanced dementia is still safety and preventing injury. This manifests primarily through managing the risk of falls, accidents in the home, and critically, wandering off.
Wandering is perhaps the most dangerous behavioral symptom.
It is. Unmanaged wandering is the #1 indicator that family members can no longer safely manage the client at home and that assisted care or a secured facility placement is required.
So what are the interventions for that?
Nursing interventions must manage this risk through environmental modification. So, secured units, alarm devices, placing simple locks high or low on doors to defeat their procedural memory, and providing safe, enclosed areas for pacing, which are often called wandering paths.
And just like in delirium, we stick to the rule on restraints.
Absolutely. Restraints are generally avoided as they inevitably increase agitation, resistance, and the potential for a catastrophic reaction. The goal is always the least restrictive environment.
Environmental structure, however, is a non-negotiable intervention for the cognitive stability of a patient with dementia.
Structure and routine are therapeutic gold. Keep the daily schedule highly consistent meals, bathing, activities at the same time every single day. Unpredictability triggers anxiety.
So any sudden changes can be a problem.
Sudden changes in environment, staff, or routine can precipitate a catastrophic reaction. If you know, for example, that the rush of shift change or the noise of the large dining room triggers agitation, the proactive nursing intervention is to move the client to a quiet area during that busy time.
We also want to maximize familiarity to provide psychological security.
Definitely. Assign the same caregivers whenever possible, as a familiar face reduces the anxiety of agnosia, that inability to recognize people, and keep familiar objects like photos of family or a favorite blanket in their immediate environment.
Now let's tackle communication mastery, specifically the choice between reality orientation and validation therapy. This is a common point of confusion for new nurses.
It really is. Reality orientation, reminding the patient of the date, time, and place, is useful only in mild early dementia, or when a patient is capable of regaining orientation, like in the post-delirium phase.
But as the disease progresses into the moderate and late stages, that technique becomes counterproductive.
Yeah.
Why does it fail in moderate dementia?
Because of the anosognosia and the significant memory loss. Quizzing or correcting them, saying, "No, your husband died 10 years ago," forces them to confront a reality their brain just cannot process. It causes shame, intense anxiety, and that resulting catastrophic reaction.
This is where validation therapy, or going along, becomes the preferred therapeutic technique.
Yes. Validation therapy focuses on the feeling or the need being expressed, not the factual reality of the statement.
So, for example, if an older gentleman insists he needs to go home to check on his children, who are now adults living across the country,
You do not argue about his current location or the age of his children. You focus on the emotion, which is the feeling of responsibility or worry.
what would that therapeutic response sound like?
You would validate that worry. "I hear you were worried about your children, and it sounds like you miss them very much." And then you redirect. "Tell me about them. Where did they grow up?" This brings them into a safe, familiar memory, since remote memory is often intact, while respecting the underlying emotion.
Let's use another example. A patient is insistent that they need to go outside to their farm to milk the cows, and it's a snowstorm outside.
You acknowledge the underlying purpose and worry. It sounds like you have a strong sense of responsibility and you are worried about your farm work. Then you redirect with a comforting activity. "It is freezing cold and snowing right now. How about we have this hot cup of tea while you tell me about the best cow you ever milked?"
And this same principle applies directly to managing agitation and repetitive behaviors, or perseveration.
It does. Arguing logically or demanding they stop repeating a question is futile. The primary non-pharmacological approach for aggression, agitation, and perseveration is distraction and redirection.
Can you give us a specific example of redirection during a known trigger event, like mealtime agitation?
Sure, if the client becomes frustrated or angry at the dinner table, maybe they're struggling with their utensils because of apraxia, you don't force them to continue. You gently shift their focus to a simple, non-demanding task nearby.
Like what?
Like, "The plates need to be cleared for the next course. Come over here and help me choose the color of napkins we should use for the dessert table." It provides movement and purpose without demanding complex cognition.
And when managing paranoia or delusions, like a patient insisting staff is stealing their wallet.
Again, arguing logically will not work. You validate their fear. "I see you're worried about your money and belongings." You help them search briefly, you often find the item where they left it, and then you immediately redirect to another activity like, "Now that we know your things are safe, let's go sit by the window and look at the birds."
Due to apraxia and agnosia, supporting activities of daily living, or ADLs, becomes central to nursing care. And the goal here is maintaining functional independence and dignity for as long as possible.
To achieve this, we have to simplify every task. We break tasks into small, achievable steps and use simple, sequential cues. When dressing, you lay the clothes out in the order they must be put on: underwear, then shirt, then pants. If necessary, you use gentle, hand-over-hand guidance for tasks like brushing teeth or bathing.
And communication during ADLs is paramount, especially when guiding a task where apraxia has caused the client to forget the sequence.
If the client is struggling to initiate bathing because they've forgotten how to sequence the steps for using a washcloth, the nurse needs to provide the object and a very clear instruction. "This is a bar of soap and a washcloth. Please wash your face and hands." We maximize cues and minimize expectations for independent initiation.
And we also want to give them control wherever possible to reduce resistance and agitation.
This is achieved through limited choices. You never present an open-ended question like, what would you like to wear today? That requires way too much abstract thinking and causes anxiety.
So
Instead, offer limited options. Do you want the blue shirt or the red shirt? And critical to all ADL care, never, ever rush the client. Allotting extra time for bathing, dressing, and meals prevents the nurse from feeling frustrated and the client from feeling pressured, which reduces the likelihood of a catastrophic reaction.
Okay, next, let's tackle the high risk of malnutrition and dehydration. What are the key nursing interventions to promote nutrition?
Due to apraxia, the inability to use utensils, memory loss, and eventual dysphagia, or difficulty swallowing, clients are at constant risk for weight loss. The single best adaptation is the use of finger foods.
And when we say finger foods in this context,
We mean simple, easy-to-handle, bite-sized foods that do not require complex utensil use. So chicken strips, cheese cubes, pre-cut sandwiches, firm fruit slices, or nutrient-dense energy bars. Always pre-cut food before serving.
And it's also important to minimize distractions.
You have to. Turn off the television, clear the table of non-food items, keep the client focused on the task of eating.
As the disease advances, we have to assess for and manage dysphagia. What are the signs of that?
The signs include coughing during meals, pocketing food in their cheeks, or having a wet or gurgly voice after swallowing.
So what are the necessary aspiration precautions?
Aspiration precautions include sitting the client upright at a 90-degree angle during meals and for at least 30 to 60 minutes afterward. We might need to utilize thickened liquids or implement the chin tuck method during swallowing to prevent aspiration pneumonia, which is a common cause of death in late-stage dementia.
Moving on to elimination and hygiene. Incontinence is common, and it requires proactive management.
We have to establish a strict, structured toileting routine, what we call prompted voiding. For example, taking the patient to the bathroom every 2 hours before bed and upon waking. We manage incontinence using disposable adult briefs and stringent perineal care to prevent skin breakdown and pressure ulcers.
And we avoid indwelling catheters.
Absolutely. Indwelling catheters introduce a massive risk of a UTI, a frequent trigger for delirium, and confused patients are prone to pulling them out, which causes trauma. Simple brief changes and meticulous skin care are the preferred methods.
And finally, we have to constantly assess for those unmet physical needs, which often manifest as behavioral issues.
That's so important. Restlessness, agitation, or sudden aggression should prompt the nurse to investigate basic physiological needs first. Is the patient in pain? Are they hungry? Are they impacted or constipated? Do they need to toilet? Often the agitation subsides immediately once that underlying need is met.
Let's discuss the pharmacological management for Alzheimer's disease. And again, these medications slow the decline. They do not offer a cure.
Right. Our primary agents are the cholinesterase inhibitors, or CIs. These are drugs like Donepezil, which is Aricept, rivastigmine, or Exelon, and galantamine, or Razidime.
What exactly is their mechanism linking back to the pathophysiology we discussed?
They work by blocking the enzyme acetylcholinesterase. That's the enzyme responsible for breaking down acetylcholine, or HE. Since the neurons that produce SIA are dying, these drugs aim to preserve and boost the effects of the remaining ACECO supply in the synapse.
So it's about making the most of what's left.
Exactly. It temporarily improves cognitive function or, more realistically, slows the rate of decline.
So caregiver education must emphasize realistic goals here.
Yes. They have to understand that the drug slows the progression of symptoms, but the disease itself is still advancing. They might see a temporary increase in alertness or memory function, but the drug will not restore lost memory.
What are the major side effects we must monitor for?
Because they increase cholinergic activity everywhere, the side effects center on the GI tract and the heart. So you see nausea, vomiting, diarrhea, dizziness, and bradycardia, a slowed heart rate. We typically administer them with food to mitigate the GI upset.
And what about the high-yield caution regarding the older drug, Packrene?
The older CI, Tacrene or Cognex, is rarely used today because of the significant risk of hepatotoxicity or liver damage. If you encounter this drug in a practice question, you have to know that it requires frequent monitoring of liver function tests, or LFTs, often every 1 to 2 weeks, especially in the initial phase.
So a history of liver problems would be contraindication?
Absolutely. A history of liver impairment or alcohol abuse would contraindicate this medication.
And finally, we have the other major class of medication.
The NMDA receptor antagonist, memantine or Namenda. This works differently by regulating the activity of glutamate, another key neurotransmitter. It helps protect neurons from overstimulation by glutamate.
And when is this one used?
Memantine is typically used in moderate to severe Alzheimer's disease and is often combined with a cholinesterase inhibitor for a synergistic effect.
We've covered safety, physical needs, and pharmacology. Now let's address the psychosocial core. Maintaining dignity and function through therapeutic activities. The focus here must be on failure-free activities.
Failure-free activities promote a sense of competence and dignity. They have to be simple, adapted to the patient's current ability, and require minimal abstract thinking. We really try to utilize remote memory as a strength.
What are some effective failure-free activity examples?
Music therapy is highly effective. Musical memory and emotion are often preserved even when language fails. Reminiscence therapy, looking at old photos, talking about fond historical memories, taps into their intact remote memory and reinforces their identity.
And simple tasks can work too.
Simple tasks like folding laundry or sorting objects provide purpose without the complexity of a new task.
And what about for physical exercise?
Because of apraxia, verbal instruction alone is often useless. The nurse has to physically demonstrate the exercises while the client simultaneously perform them. This reliance on visual cues and imitation bypasses the cognitive deficit.
And the setting matters.
A lot. Remember context. Individual or small group activities are always preferred over large groups, which are easily overwhelming and can trigger anxiety and moderate dementia.
Finally, let's talk about the most crucial support in long-term care. Supporting the caregiver. This is a consistently high-priority concept in clinical practice and testing because caregiver role strain is rampant.
Oh, caregiver burnout is often inevitable without intervention. Recognizing the signs of overwhelming stress is key. Physical exhaustion, increased irritability, neglecting their own health, or statements like, "I have no life anymore, I can never leave the house."
How does the nurse respond therapeutically to that kind of severe emotional strain?
First, we have to validate the profound difficulty of their experience. I hear how emotionally and physically overwhelming this is for you, but validation isn't enough by itself. We have to immediately pivot to action-oriented assistance. Let's explore some options for getting you regular scheduled breaks.
And what are the two main interventions we promote?
Respite care, which is planned, temporary relief for the primary caregiver, and support groups. Support groups are incredibly beneficial because they provide interaction with others facing the exact same, often isolating challenges. It helps reduce stress and normalize their struggle.
The airplane oxygen mask analogy.
Exactly. We have to counsel them using that analogy. You cannot pour from an empty cup. To provide good, safe care for your loved one, you must first take care of yourself.
A difficult but necessary component of caregiver counseling is managing expectations.
Yes. The nurse must clearly teach the family that dementia is progressive and irreversible. The client will not recover or regain functional independence. This painful, honest truth allows families to adjust their emotional and financial expectations and make necessary long-term plans, like home modifications or securing future placement.
And linking back to overall safety, what are the final general health maintenance points?
Aggressive pain management, preferably with non-opioids like scheduled acetaminophen, is essential because uncontrolled pain severely worsens confusion and agitation. We maximize sensory input by ensuring current, functioning eyeglasses and hearing aids are in place. And we maintain vigilance against polypharmacy. Unnecessary medications increase the risk of triggering delirium on top of the dementia.
So let's synthesize the massive amount of information we've covered. We've established that these cognitive disorders are defined by their trajectory and their primary nursing priority.
Delirium is the acute, sudden, treatable medical flag with fluctuating consciousness. The priority is always immediate safety and being a relentless detective to identify that physical or pharmacological root cause, be it infection, metabolism, or medication. Once the cause is treated, the client should return to baseline.
And dementia is the chronic, insidious journey of progressive decline. Here, our nursing role shifts from acute detective work to compassionate guide, maximizing function, simplifying the environment, and utilizing advanced communication techniques like validation and redirection to protect dignity and prevent injury over the long term.
That's right. You, the nurse, are the safety advocate, the environmental controller, and the consistent source of humanity in every single one of these cognitive situations.
And that raises an important question for you, the learner, to consider as you step into practice.
Since agitation in moderate to severe dementia is so often triggered by an unmet need, pain, hunger, or the need to toilet, that the patient cannot articulate due to their deficits. How might proactively embedding highly structured routines, such as scheduled toileting and scheduled small meals, fundamentally shift your care?
Think about how moving from reacting to symptoms to anticipating and preventing distress before it even starts.
That is what defines true excellence in chronic cognitive care.